Morning, good afternoon, whatever time of day it is that you're joining us, and welcome to Penn State College of Medicine Glomerulonephritis and Kidney Transplantation Echo. We're delighted to have you join us for this session. My name is Jessica Byler. I'm a member of the Echo team, and I will be starting today's sessions with the announcements and introductions. If you have not already done so, please put your name and email address in the chat for our record keeping. Please stay muted unless you're speaking. So that's going to be *6 if you're calling in on the phone, or that microphone icon on Zoom. And we do encourage the use of webcams, but if you have any technical issues or don't want to use a webcam, the chat function is a great way to communicate with us. We are recording these sessions so that we can share them with you and your colleagues later. And in the spirit of echoes, I'll teach, I'll learn, we will be on a first name basis during the sessions. So I'm going to turn it over to Umar so that he can introduce or help introduce the hub team, and then we'll start with a presentation. So I will let you wonderful gentlemen take it away.
Thank you, Jessica. So today, as you said, good afternoon and good evening and good night, everyone. So it's 10 p.m. in Pakistan. It's 1 p.m. here. So today we will be talking about the Mgrs. So historically, it used to be Mgrs, monoclonal gammopathy of undetermined or unknown significance. And I think now we have a new twist to it, which is the renal significance. And you all know our favorite and the famous Dr. Agha. So he will be leading the session. So Irfan, would you like to share your slides and take over?
Sure. So I'm looking at everybody. So let me do this. Okay. So I'll start by apologizing for last time. Something unexpected came up and we had to cancel. So my profound apologies. So we'll try to make up for that at some point. Thank you for accommodating me. So we're going to talk about monoclonal gammopathies and then what their renal significance means. This has been a rapidly moving field, as we'll see that most of the stuff that's been done in this field has happened in the past 10, 15 years. This is a CME talk. I have no relevant disclosures. So the story begins of all these paraproteins in kidney disease in 1844. It was a dark and stormy night in Scotland, and a grocer, Thomas Alexander Bean, who was on vacation in Scotland, had one drink too many and vaulted over an underground catacomb. He fell down and developed excruciating chest pain. He went to see Dr. William McIntyre at 84 Harley Street, which actually is still a medical office building in London. He was found to have severe pains and peripheral edema. Dr. McIntyre was aware of Dr. Bright's work on kidney disease and proceeded to test Mr. McBean's urine for albumin. He used the standard test that was available for albuminuria at this time, which was the heat precipitation test. And then what he found was he also did the Heller's test, which was addition of nitric acid to the urine. And what he found was that this particular urine sample was behaving a little abnormally. There was no immediate precipitation of albumin, but once he continued to heat it, the previously cloudy or turbid urine actually clarified. So he actually sent this patient to two other people. He sent him to Dr. Watson, not the Sherlock Holmes one, but another physician who was practicing at that time. And both of these gentlemen sent the specimens to another physician who we now know these proteins eponymously by, Dr. Bence-Jones. So Dr. Bence-Jones actually studied this a little bit more And he actually thought that the compound in this urine was a deutoxide of albumin. And he actually calculated a molecular formula for that, which is freakishly close to the molecular formula of the kappa and lambda light chains today. So that was pretty interesting. And they started looking at some connections between these proteins, which are behaving atypically different from albumin, and mollitus osseum, which was the progenitor of the syndrome we call multiple myeloma. So this was about 150 years ago. The term plasma cell was coined by Waldeer, he of the ring, in 1875. Over the next 50 odd years, we started learning about the different proteins in the blood. Tiselius discovered 4 bands in equine serum. They call them albumin, alpha, beta, and gamma. He tried to publish this paper in 1937. Actually, this paper was rejected. So there's hope for all of you guys whose papers are rejected. Don't give up. You may be onto something. And then in 1951, Kunkel and Tiselius introduced filter paper electrophoresis. And John Waldenstrom, after whom the syndrome of Waldenstrom's macroglobulinemia was defined, described the first monoclonal spike in both multiple myeloma patients as well as Waldenstrom's macroglobulinemia. And then in about the next several years, in the mid-1950s, we've started figuring out what these proteins are actually made of. And Leonard Korngold and his technician, Rose Lipari, identified different classes of these Bence-Jones proteins in the urine. And they actually demonstrated that anti-sera to Bence-Jones proteins also reacted with the myeloma protein in the blood. So they were able to figure out that the myeloma protein in the blood is the same as the protein that's being excreted. And so if you look at their names, K and L, that's where the kappa and lambda for the light chains comes from. And so this was the emerging paradigm, mid-1950s. We know there's antibody-producing cells. Waldeer called them plasma cells. Probably that's what they are. They are developing monoclonal proteins in the blood and urine. And at some point, these are associated with myeloma, Waldenstrom's macroglobulinemia, and frank lymphoma. So that's the paradigm. Comes in Robert Kyle, who was the grandfather of myeloma science at the Mayo Clinic. And so he did this very important study in 1978. They looked at 241 patients with monoclonal proteins in their blood, and they followed them for about 5 years. And they found that more than half of them had no change. Nothing happened. About a quarter of them died before the 5 years were completed of different causes. And about 20% of the cases, either there was an increase in the monoclonal protein or they actually developed disease. So about 10% of the people in this cohort over a period of 5 years went on to develop various types of diseases like multiple myeloma, Waldenstrom's macroglobulinemia, and lymphoma. And they also found in a subsequent paper, this was done in Minnesota and Olmsted County, where they tested samples from more than 20,000 residents, and they found that the prevalence of MGUS, monoclonal gammopathy of uncertain significance, which is a term that Dr. Kyle coined, is about 3.2%. So about 3% of people at the age of 50 would have an abnormal protein in their blood. Doesn't mean that they've got myeloma, they just got this protein in their blood. This jumps to over about 5.3% at the age of 70. So as you're getting older, the prevalence of these abnormal proteins is going up, but there's no cancer. And so it is unclear which way this worm is going to turn. It could be no change, which is the more likely outcome, or they may develop some disease, or the protein may increase. So we don't know which way this is going to go. So this is why it's called monoclonal gammopathy of uncertain significance. So these operative definitions were actually these started coming together in the 1980s. MGUS, monoclonal gammopathy of uncertain significance. If your M protein is less than 3 grams per deciliter, your plasma cell burden in the bone marrow is less than 10%, and there's no organ damage, then you're in the MGUS territory. Now, if your protein goes above 10 and your plasma cells are about 10% plus, you've got what is known as CRAB criteria, hypercalcemia, renal insufficiency defined as a creatinine clearance of less than 40, anemia defined as a hemoglobin of less than 10 or below, or 2-gram drop below baseline, and bone lytic lesions, then you have a diagnosis of myeloma. And in the middle is this entity called smoldering multiple myeloma, where you've got an M protein which is more than 10. Your plasma cells are more than 10, but they are less than 60. So it's kind of tripping these two, but there's no organ damage, no CRAB, nothing else. So the idea is, as you go from MGUS to smoldering to multiple myeloma, your chances of developing frank disease go up. Now in 2014, the International Myeloma Group added 3 more things into features that would actually put patients at high risk for progression. One of them is a free light chain ratio of involved to uninvolved of more than 100. So if your kappa is 1000 and your lambda is 10, then your involved to uninvolved is 100. Your plasma cells in the bone marrow exceed 60%, and you have more than 1 bone marrow lesion on an MRI. So if you develop those lesions, then you would be at high risk for progression of disease. And similarly, for other cell types, for instance, lymphoplasmacytic clones, you had similar criteria. Give me just 1 second, guys. Sorry about that. So for lymphocytic clones, if you have an IgM MGUS, so lymphoplasmacytes are going to produce IgM, which is good because it gives you a little bit of a tip off on how to treat it. But IgM monoclonal protein less than 3 grams per deciliter, lymphoplasmacytic infiltration of the marrow less than 10. Again, if you trip this, you've got a higher level of monoclonal protein, more than 3. Your lymphoplasmacytic infiltration is 10. Now you've got organ system involvement. You've got precipitation of Waldenstrom's macroglobulinemia. And the organ system involvement in this, we all know, is hepatosplenomegaly, lymphadenopathy, and anemia and thrombocytopenia. And if you're sitting in the middle where you're kind of tripping these levels, but do not have any organ system involvement, then you're in smoldering Waldenstrom's macroglobulinemia. And so similarly for lymphocytes, you've got clonal B lymphocyte proliferation, and then eventually you develop B-cell lymphoma. So then the paradigm for this was adjusted. You've got antibody producing cells, you've got clonal proliferation, that leads to paraprotein generation. If there's no consequence of this, it's just protein sitting in the blood, then you've got MGUS. But if you meet tumor burden criteria, then you have a diagnosis of cancer. So this was the paradigm in the early 2000s. We were blissfully ignorant of anything else going on. Sami Nasser comes in, and so he publishes a paper in 2004. Not this paper, this one is a follow-up paper, but the first paper he put in was in 2004. And what he described was monotypic deposits. So let's pay attention to this page. This is, all of us are nephrologists. This looks like an MPGN type picture. The glomeruli, both of these look very lobulated. You can see that the capillary spaces are fairly obliterated, and there is hypercellularity in there. Mesangium is expanded a little bit. So you can kind of, okay, this is an MPGN pattern. Normally, we talked about this a couple of sessions ago. When you've got MPGN, you look at the immunofluorescence, which is very important now. And in the immunofluorescence, if you see immunoglobulins and complement, then you say this is an immune complex driven process. Could that be an IgA or a lupus or immune complex GN because of infection, et cetera, et cetera. But in this particular case, what he saw was there was kappa staining, but no lambda staining. And the IgG, the immunoglobulin, was just of the IgG3 class. So this was a monoclonal IgG3 kappa protein, which was driving this process. This patient did not have myeloma. He did have a monoclonal IgG kappa in the blood. So the thought process now was that there is something in the blood which is driving this reaction in the kidney. So this series of papers that Sami Nasser published are the primordium of the science of MGRS. So now you have had to adjust the paradigm. You got an antibody producing cell which undergoes clonal proliferation, generates a paraprotein. Again, if at any time it meets tumor burden, we're out. We fold because now you've got cancer, you've got multiple myeloma, you've got Waldenstrom's macroglobulinemia, you got lymphoma, we're out. This is not a MGRS type situation. But if you are not meeting cancer definition here, then this paraprotein can go and take many different routes. It can be of no consequence, like in Kyle's series, there was a bunch of paraprotein which was of no consequence, and that we will still call Mgrs. But like in the case that Sami Nasser actually presented, if you've got this deposition of monoclonal paraprotein in the kidney, which is then driving a process, then this would become MGRS, monoclonal gammopathy of renal significance. And interestingly, now we are finding out these paraproteins can cause other badness. They can cause peripheral neuropathy. They can cause cardiomyopathy. So if there is other end organ effects that are going on, then we will call it MGCS, monoclonal gammopathy of clinical significance. So we are concerned about MGRS today. So this term MGRS and semantics are very important here. If you got myeloma, you don't have to worry about this. This is specifically to any clonal, so not a polyclonal, a monoclonal B cell or plasma cell disorder. It is a proliferative disorder, clonal proliferative disorder. It has to meet these two criteria. You need to find a kidney lesion with evidence of interaction of the monoclonal protein with the kidney. And there's two exceptions to that, and we'll talk about it. And then the underlying B cell or plasma cell clone should not meet the tumor definition. If it meets the burden for burden of definition for multiple myeloma, we're done. Now, so the conceptual difference in MGRS is that it is not the amount of protein that is causing a problem. So in multiple myeloma, the clinical manifestations happen because of tumor burden. There's a lot of plasma cells, and so they're either going to elbow out of the marrow, leading to anemia and thrombocytopenia and all that, or they're going to produce a boatload of antibody, boatload of free chains and heavy chains or whatever they're producing, and then those are going to cause problems. So the commonest kidney manifestation in myeloma is cast nephropathy, and that's just brute force. A lot of protein comes in, goes into the tubules, plugs everything up, generates an inflammatory reaction amongst other things, and it's just a brute burden of disease. So these are in myeloma or in Waldenstrom's macroglobulinemia or in B-cell lymphomas. These are the tumor burden related manifestations that actually drive diagnostic criteria. In MGRS, the amount of protein is low, so it is not the burden of antibody, it is the physical and chemical properties of that antibody that drives various types of reactions. So the quintessential MGRS syndrome that we have known of and treated forever is amyloidosis. And everybody on this panel knows that amyloidosis is usually driven by a lambda light chain. And why is that? Because the types of light chain that are being produced in amyloid perhaps have a propensity to deposit in a certain way in certain places, and we'll talk about that. So it is almost everything is in the antibody. So this is a very, very interesting experiment. So on the left side, all you're going to see is murine tissue. On the right side, you're going to see human tissue. So this is several patients, not the same patient, who've got different types of myeloma-related illnesses. So you take their urine, purify the antibody, inject it into the peritoneum of the mouse. So now what's going to happen to this poor mouse? He's going to develop diseases which are eerily similar to the diseases that the human had. So in this particular guy, the guy had cast nephropathy. The mouse develops cast nephropathy. Here, the patient had crystalline nephropathy. The mouse develops crystalline nephropathy. Amyloidosis, amyloidosis. So just transferring that antibody passively generates the same amount, same lesions that the host had. So this is fairly interesting evidence to say that most of what's going on in the kidney is just a reaction to the type of antibody that is being generated. And so different antibodies, different types of light chain, different types of heavy chains are actually processed through mesangial cells differently. So in this particular case, you've got this mesangial cell, and free light chains come in through different sources. There's a putative light chain receptor on these mesangial cells, and some free light chains, for instance, the amyloid type light chains, are processed through the lysosomal compartment, and they eventually are going to develop fibrillar deposits of the amyloid type. On the other hand, there are other types of light chains that are processed through the endosomal compartment, and they are actually going to eventually end up developing granular deposits, which are more suggestive of light chain deposition disease. So this is why sometimes when you've got myeloma, somebody will develop amyloid. Sometimes when you got plasma cell dyscrasia like amyloid, they will develop amyloid-like deposits. Other patients who've got myeloma are going to develop light chain deposition disease, cast nephropathy. It all depends on the type of antibody being generated. And so as predicted from the glomerular handling of macromolecules, higher molecular weight paraproteins, which have got heavy chains, IgG, A, and M, will interact and probably start depositing in the glomerulus, whereas the free light chains are going to filter down and go into the tubules. So over here, if you're going to develop intraluminal crystals, for instance, there would be specific types of light chains that will develop cristaglobulin-induced nephropathy. There will be specific types of light chains that are going to develop MIDD, monoclonal immunoglobulin deposition disease. If amyloid type fibrils are being generated through deposition of these light chains, then you'll have amyloid either in the blood vessels or in the glomerulus itself. If you go down into the tubules, you're going to have cast nephropathy. In the glomerulus itself, you can have immunotactoid disease. You can have PGN-MID, proliferative glomerulonephritis with monoclonal immune deposits. You can have C3GN. So there's a whole cornucopia of disease processes that follows. But it sounds terribly complicated, but it's not. I'm going to slash it all out of oblivion because you don't need to know what's in the kidney, to be honest, as long as you know that there's a paraprotein operative in the kidney, because we don't have therapy. We're trying to develop it, but we don't have therapy targeting anything at the glomerular level. We can't make the amyloid fibrils melt away. This is why if you've got amyloidosis, which is well set, you may not reverse that because those fibrils are there. They're going to continue to be there and cause damage. We can't reverse the immunotactoid fibrils. We cannot, or the microtubules. We cannot take away the deposits that have led to PGN-MID. However, what we can do is decrease the generation of these antibodies, actually all of these proteins. So all our therapies are actually targeted on taking that away. So it's important to know what these are. It's important to know what the kidney is doing and what the nuances of every disease is, but it's not terribly important that you pigeonhole everything 100% as long as you've got the gist of what's going on. So clinical presentations are myriad. They can present with acute kidney injury. Now this is technically not supposed to be in here, but when you've got a very heavy burden of monoclonal proteins because of myeloma, you can develop cast nephropathy, but that's technically not an MGRS. It's just a concept figure here. You can develop thrombotic microangiopathy. I'll talk about that a little bit more. Then you can present with nephrotic syndrome or progressive kidney disease like amyloidosis, MIDD. You can develop a nephritic or nephrotic picture, some proliferation, some deposition, some filter damage, some hypercellularity, so PGN-MID, cryoglobulemic disease, C3G and immunotactoid, etc. And then you can have proteinuria, non-nephrotic and progressive kidney disease in some of these other disorders. So this is a huge spectrum. So, you know, whenever you have these presentations and you've got a paraprotein, that should actually sharpen your resolve to go ahead and biopsy them and not attribute it to diabetes, which we sometimes usually end up doing. So how do you approach these diagnoses? What you want to do is to first detect the paraprotein, then define the pathology, and then hunt down the clone, because that's where you will treat. We're not going to treat the paraprotein. We could in some cases, but doesn't work well. We are not going to obviously alter the renal pathology by our therapy. What we can do is to kill the clone that is producing the monochrome proteins. So how do you look for that? The monochrome proteins can be produced as an entire immunoglobulin from that clone. It could be an entire immunoglobulin with an extra amount of light chains. We can have light chains only, we can heavy chains only. So this is very variable depending on what the pathology is and what the cell is producing. These can actually be transient. So sometimes you can see a spike when somebody is sick. You repeat it after 3 months, it's all gone. So we have to be careful that we don't overreact, especially when there's other illnesses going on. And then the levels can be up and down. They can remain stable. They can be up and down dynamic. So all of these things need to be considered. So when these light chains are filtered through the glomerulus, they're actually picked up by the proximal convoluted tubule. So here, you know, every nephrologist knows megalin-cubulin. These are clathrin-coated pits. So these light chains come in, they're picked up by the clathrin-coated pits. They are metabolized. So about 500 milligrams of light chains are released into the circulation every day. 80% of these are in the extravascular space, so they kind of diffuse out their small molecules. Their removal is through the kidney, and this process of endocytosis in the proximal convoluted tubule is so effective that only about 1 to 10 milligrams of these every day make it into the urine. So very effective removal of light chains that are filtered by the kidney. And how do you detect them? So I showed you the emergence of electrophoresis for these, and this principle is pretty much the same as Tiselius propounded in his paper in 1937. You put the specimen on a filter paper, apply a current, and you see these things move on gel based on their charge and size. Fairly straightforward. Usually you see 5 zones, albumin, which is the largest, and then alpha 1, alpha 2, beta, and gamma, alpha 1, alpha 2, beta, and gamma. And so, and the beta can sometimes have 2 peaks. So that's kind of what a normal serum protein electrophoresis looks like. It detects intact immunoglobulins. The sensitivity is about 500 milligrams per liter. So it's not highly sensitive. But if you add an immune component to this,
then it will detect at about 150 milligrams per liter. And it can actually, since now you're putting in anti-sera in there on that gel, so if it's an anti-IgG, which is lighting up, you know that the immunoglobulin you're talking about is an IgG antibody, so it'll define your isotype as well. And UPEP and IFE usually, in most cases, are not helpful, but in amyloid monoclonal immunoglobulin deposition disease, they are helpful. So I still, when I'm trying to figure out if there's a monoclonal protein of interest or not, I check an SPEP, I check a UPEP, and I use immunofixation on both to make sure that I'm doing as much of a sensitive test as possible. Some people like to do it on a 24-hour urine specimen. It is said to increase the specificity, although there's never been a head-to-head, I think, to my knowledge. The reason people do it on a 24-hour specimen is because that's how these studies were validated. But in any case, you can do it on a 24-hour specimen. If I'm doing a screen, then I usually don't do it on a 24-hour specimen. But if I'm really trying to look for it and can't find it, especially in diseases like PG and MID, I would then sometimes inconvenience the patient to do a 24-hour urine specimen. Free light chain assays, which came out about almost 20 years to the day today, have actually increased our sensitivity to pick up these paraproteins at a much earlier stage. So this is probably the most sensitive test. These are all, well, the first two, the latex and the free light, which is the sheep RBCs, are both nephelometric tests. Nephelometry is an immunology technique where you actually look at the serum and scatter of light in certain degrees based on what is in that serum to figure out what you're dealing with. So the commonest is the free light assay. The latex assay is becoming a little bit more common as well, and we'll talk about it. And then a Luminex assay is being developed as well. Urinary exosomes and mass spec techniques are being developed to be a little bit more thorough, because finding a paraprotein becomes very, very important. These are not available for clinical use at this time, even in the United States. These are mostly research tools, but we'll talk about why it is important to find the most sensitive way to find these paraproteins. So this is free light chain. Normal values go up. So on column A and B, you're looking at kappa and lambda. And so what you're seeing is, as you get older, the levels in the blood start going up, which is probably because as you get older, your GFR goes down, but you can see that the ratio remains remarkably stable. And this is the normal ratio. So between these two lines is freedom from any disease, and a normal ratio is defined as 0.6. If your GFR is normal, the range is 0.2 to 1.6. Now, the production rate of kappa to lambda is about 1.8 to 1. So there's twice as many almost kappas that are produced, but kappa is half the size because lambda circulates in dimetic form. So kappa's molecular weight is about 22. Lambda is 45, and their primary disposal is renal, and therefore kappa's removal is more expeditious than lambda just because of the size function. There's a secondary removal through the reticuloendothelial system, which is in the background, which is weight agnostic. Now, when there's progressive kidney disease, so as your kidney numbers start going up, your serum free light chain concentrations start going up. And essentially what happens is your kappa starts backing up a little bit more. And when that happens, your production rate is higher, your removal is going down, the kappa levels start going up. So your kappa lambda ratio with increasing degrees of chronic kidney disease is skewed to the right. So your instead of 0.6, your your median is 1.1 and the range is 0.3 to 3.1, depending on how much renal dysfunction you have. So this must always be kept in mind when we're seeing somebody with a GFR of 25 and their kappa lambda ratio is 2.2 or something. I won't start jumping up and down unless there's a reason to. The latex assay actually correlates very well with the free light assay, and the only reason this is probably becoming more prevalent is that it is on a Siemens platform. So wherever there's Siemens equipment, they're using this assay. So one needs to know which assay you're doing, and if you're doing a latex assay, just probably do serial latex assays rather than switching back and forth because the absolute values may be different. And a Luminix assay is being developed. I haven't seen this. In our labs yet. I think somebody's not muted. Would you be able to mute everybody? All right, thank you.
I just did.
Thank you. So Luminix assays are not being used, but they are being developed. And the reason I think these will come up, they correlate very well with free light assays. But I think the reason these might actually become the assays of choice in the future is because these tests are very highly automatable. So all you want to do is, load the serum specimens and run the beads and you get an answer. So they are very highly reproducible and require minimum tech input. So once you know that there's a paraprotein there, you have to figure out, okay, is the kidney disease being run by this disease process or not? There's a lot of people with chronic kidney disease. We know that 3 to 5% in the 50 to 70 age group would have an Mgrs. So who do you biopsy? So, you find these people who may actually have an Mgrs. So how do you identify the target-rich environment? Obviously, anybody with mild chronic kidney disease and some abnormality in their SPEP, you're not going to run to biopsy them. So there's 2 or 3 things which you want to look at before you start deciding, okay, I need to biopsy. If they've got an AKI which is not otherwise explained, or you're having a rather rapid deterioration of kidney function, they've got diabetic nephropathy, but they're losing 3 mLs per month of their GFR or something, and like something else is going on. So you go ahead and do a biopsy. And as time has gone by, my index of suspicion to do biopsy in these patients has actually gone down. So I biopsy more than I used to in the past. Proteinuria, usually more than 1 gram. If you've got proteinuria, hematuria, if you've got Fanconi syndrome, something telling you that there's something not right either in the glomerulus or the tubules or the interstitium of that kidney, then you want to go ahead and biopsy that. And if the sediment is completely bland, the renal function is stable, decline rate is as you would expect, even if they have a type of kidney disease, then I would just follow the monoclonal protein, follow the sediment. If something changes, I'll come back and biopsy. But usually I end up biopsy in this domain. I haven't seen a lot of acute kidney injuries in this, but I've seen a lot of proteinurias, hematuриas, and you biopsy, you find stuff. And so now this is a complicated slide, so I don't want you to take a deep breath in. We're not going to talk about it because, like I told you, these are different patterns. These are all caused by the monoclonal protein. So the important thing is you have to determine that there's clonality there, and that's half the battle because you treat them all the same. So this is how we think about MGRS syndromes today. So we start with looking at monoclonal immune deposits there or not. So you'll be saying, what do you mean by that? Because you just said that you will need to demonstrate that there is monoclonality. So why do you have this? We have this because there's 2 caveats in there, and I'll come back to them last of all. So we'll go over the biopsy specimens where we actually do find monoclonal immune deposits, right? So we look at those deposits and we look at them under the electron microscope. Now you do not have electron microscopy, so you don't have to worry about it. So what we are going to do is look at them under the electron microscope and see what kind of fibers we're looking at. If they are fibrillar, we're talking about either amyloid or monoclonal fibrillary. This is a disease which is really diminishing in its scope, so this may actually be reclassified soon. So basically, if you find fibrillar organized deposits, you're probably talking about amyloid. If you've got microtubular deposits, so I mean, this is difference in size. When you look at it under the electron microscope, amyloids are about 8 to 10 nanometers. Immunotactoid is 25 to 35 nanometers in size, or it could be cryoglobulinemic deposits. So both of these have a monoclonal IgM component to them, so that qualifies them as part of this syndrome complex. So if you've got microtubular organized deposits, you're talking about either immunotactoid GN, or you're talking about cryoglobulinemic GN. And if you've got inclusions and crystalline deposits, I've never seen a case of this yet, but I'm hoping that I shall at some point. So you've got light chain proximal tubulopathy, crystal storing histiocytosis, etc., etc. So this totally depends on the electron microscopic appearance of these. Now, if you've got non-organized deposits, so you've got monoclonal immune deposits which are not organized, then you're talking about MIDD, monoclonal immunoglobulin deposition disease, and these are of 3 different types: light chain, heavy chain, light and heavy chain. And then you've got PGN-MID, proliferative glomerulonephritis with monoclonal immune deposits. So this is the scope of MGRS syndromes. The common thing is that each one of them are driven by a monoclonal protein. So that is actually demonstrated on immunofluorescence. So you have a diagnosis of a monoclonal protein. So in the case of amyloid, you've got a lambda monoclonal protein demonstrated here, fine. And then you do Congo red, you can do kappa lambda stains, and you can make the diagnosis. You don't need electron microscopy to make this diagnosis. So similarly, in all of these, most of these categories, you can actually determine the clonality, which is determined on immunofluorescence anyways, and then you can do some other maneuvers. Now, monoclonal fibrillary is typically DNA JB9 negative. So if you're finding DNA JB9, then you're probably not talking about monoclonal fibrillary. And that's something that you can do on immunofluorescence as well. So you don't need electron microscopy. So once you've put them in one of these buckets, then you can get ready and start treating them. Now, we carved out a caveat that no monoclonal immunoglobulin deposits detectable. So how does that work? There's 2 conditions in which this works. One is C3 glomerulopathy, and the other is thrombotic microangiopathy. And so I cannot do a talk without having a complement thing here, but we'll be very, very brief. So in C3GN, we talked about how there's an imbalance in the alternate complement pathway, pro-complement and anti-complement forces. So sometimes these monoclonal immunoglobulins that are circulating in blood actually act as C3 nephritic factors. So they egg on the alternate complement pathway to get active. So you're not going to see that monoclonal protein in the kidney because it's not depositing in the kidney. It's doing the C3 nephritic factor thing in fluid phase. But once it does that, it activates complement in the kidney. There's this MPGN type picture. When you do the immunofluorescence, everything is dark. No IgG, no IgA, no IgM, no kappa, no lambda. It's all dark. But when you do the C3, it lights up. And so you now have a diagnosis of C3GN. And in adults, about 60% of these C3GNs are actually driven by monoclonal proteins. And so in this particular case, you're going to treat the monoclonal protein. You're not going to treat the C3GN. I mean, you'll probably give them some steroids and all that. But the way to treat this would be to treat the monoclonal gammopathy. Now, there's one other thing that I would, before I go on to the next one, the other caveat was thrombotic microangiopathy. So that's in this classification on a provisional basis, because sometimes these monoclonal proteins are directly toxic to the endothelium, They generate a thrombotic microangiopathy response, but they're not actually depositing in the glomerulus per se. So in that case, if you've got a monoclonal protein, you've got TMA, you say maybe one is related to the other, but you're not going to find the smoking gun because that monoclonal protein is actually not deposited in the kidney. Now, one other thing that we want to talk about, and we've talked about this phenomenon before, PG and MID with mass deposits. What does that mean? So you've got this kidney that looks like it's got an MPGN pattern. When you actually do the immunofluorescence, everything is dark, but the C3, which is on panel E here. So when you look at this, you say, well, these are pronase treated, so ignore these. So this is what the immunofluorescence for IgG, IgA, etc. looks like. The only thing that's lighting up is panel E, which shows that there's C3. And when you look at the electron microscopy, there's a bunch of deposits there. So you would say, okay, this is all consistent with C3 glomerulopathy. Now, what is happening here, though, is that there are antibodies which are not picking up the immunofluorescence stain. But once you treat this paraffin-embedded tissue with pronase and proteases, other proteases, it actually unmasks their binding sites. And when you put in IgG and IgA sera now, they will light up. So essentially what this person really had was an IgG C3 deposit, which was a monoclonal deposit because it was an IgG C3, Kappa C3 deposit, and it was an IgG Kappa paraprotein that was driving this proliferative response, just like the index case that I showed from Nasser. And the only way we were able to correctly classify this was by doing the pronase digestion. Otherwise, we would have mislabeled this as a C3GN. So sometimes these things are hiding in front of our eyes and we can't see it. So monotypic IgA is very well described. So you've got two panels here. On the left side, you've got a mesangial type IgA. When you do the IgA stain, it lights up in the mesangial fashion. On the right panel, you see a little bit more of an angry glomerulus. There's endocapillary proliferation and almost formation of a little bit of a crescent here. And again, here you see IgA, which is lighting up in the mesangium as well as in the capillaries. So this is a little bit more angry compared to this guy here. Now on this particular gentleman, the lambda stain is lighting up. The kappa is completely quiet. So it's an IgA lambda monoclonal protein that is driving this process. On the other hand, on the right side, it's an IgA kappa protein, which is driving the process. Now, especially this IgA lambda can become very, very troublesome because, as you know, in IgA deposits, especially in, and as well as in some IgA dominant post-infectious GNs, the predominant light chain is lambda. So you have to be very, very careful in how we classify these. But there is a signal. Now, this is by no means a randomized trial, but by no means big numbers, a total series of what, 14 cases or something. But there was a trend or a signal towards better response if clone-based therapy was given rather than traditional immunosuppression. And we'll come back to this, but I wanted to present this paper so that we are aware that these things can happen. Similarly, there are monotypic membranuses that are described. And so you'll have an IgG3 with a kappa paraprotein driving the membranous. And so there's a whole way to think about these. If there is more than one IgG class and the PLA2R is positive, this is probably not an MGRS. If you've got more than one IgG subclass, and even if the PLA2R is negative, you're still not dealing with an MGRS. But if you've got a single IgG subclass and the PLA2R is positive, you're probably dealing with PLA2R associated membranous glomerulopathy. Now, this particular paper in 2017 says MGRS is unlikely, but there have been a handful of cases described of a PLA2R clone, which was actually monotypic. And then if there is a single IgG class, so IgG3 with Kappa, and the PLA2R is negative, then you're probably dealing with an MGRS or possible MGRS, and you have to go and look for a clone and make sure that you don't miss that monotypic disease, because the treatment then would be different, wouldn't it? And so how do you find the clone? Bone marrow biopsy is the first go-to. There are some diseases in which you can find it. In some diseases you can't, and we'll take a look at a graphic that kind of underscores that issue. And then you have to take some more steps to define that. So let's take a look at this. So these are different papers which are looking at the propensity of us finding a clone. So this light green here is B cell clones, blue here is plasma cell clones. This dark green here is no clone, that we didn't find anything at all. And the yellow is lymphoplasmacytic clones, so Waldenstrom's, right? So in this particular series, they looked at it and tried to find clones in light chain deposition disease, right? And what they found was in a good 65% of the cases, in light chain deposition disease, they were able to find a plasma cell clone. So this is where sometimes your morphology is going to give you a clue of what you're likely to be treating. So light chain deposition disease, more probably plasma cell clones. On the second number is you couldn't find a clone at all. PG and MID, what a sorry state of affairs. 95% of the time, you're not going to find a clone. That's not good, because now you don't know what to shoot at. Immunotactoid glomerulopathy. It is kind of a potpourri. You can have a B cell clone. In some cases, you have a plasma cell clone. In some cases, you have a lymphoplasmacytic clone. And in a good 50% of the cases, you're not going to find a clone. Again, PG and MID, another series, some B cell clones, some plasma cell clones, but in a good 75% of the case, nothing. So they really had better luck than this particular series. So in all series, you're probably in about 45% of the case, you're not going to find a clone, which is a problem. Because if you don't find a clone, how do you treat it, right? So here's the management principles for MGRS. So we're not going to talk about every single disease we can, but we're going to talk about big principles. How do you approach these diseases? So the first thing is you have to demonstrate a paraprotein. You have to confirm renal diagnosis, do a biopsy. So in most of these cases, you'll do a kidney biopsy, you'll do all the tests for paraprotein, then you'll do a kidney biopsy, and then you'll have to define the clones. You'll probably have to do a bone marrow biopsy as well. So that's what leads to complete diagnosis in most cases. Now, myeloma is a different animal. It's not an MGRS syndrome. So if you've already got myeloma, in most cases, you don't need to do a kidney biopsy. You can just treat the myeloma and see what happens to the kidneys. And some situations where you do, especially if it's been sitting there for a while, but other than that, you don't. Now, once you've defined, okay, this is what it is, what regimen do I select? That's a very complicated decision-making process, and we'll kind of get a taste of that. And then you implement and deploy that regimen, and then you have to go and monitor the hematological response and continue managing the kidney disease. So very, very complicated diseases to take care of. And, you know, people fall off their chairs. Even hematologists fall off their chairs when they say, you're crazy, I'm not going to treat this 5% clone, I've never done it. You know what I tell them? I tell them, you've been doing it for 35 years. Why? Because we've been treating amyloid forever, and we always target plasma cell clones. And how much is the percentage of plasma cells in amyloid? Usually less than 10%, right? So the paradigm is always there. So that usually calms the hematologist down. They scratch their head and then say, well, yeah, that's probably right. So what do you want me to do now? So they convert fairly quickly afterwards. So this is just the evolution of therapy for amyloid. Stem cell transplant became fairly commonly done for amyloid in 2002. And there's been great advances in the various different drug classes that we have. So I've kind of tabulated them over here. So this is all the things that we as nephrologists are now going to need to get comfortable with. Many of these I don't prescribe myself. I have my hematology colleagues prescribe them, but we need to work with them in close collaboration, and many a times have to hold their hands through this. Because these actually, we think, oh, this is too toxic. But when you really think about it, this is not as toxic as cyclophosphamide and prednisone, which we are very, very, comfortable giving to patients. So the proteasome inhibitors, bortezomib, carfilzomib, and then the oral ixazomib. We know in monoclonal antibodies, the B-cell antibodies, rituximab is the quintessential drug for that. But now there's new and improved multiple different types of CD20 antibodies. There's CD19 antibodies coming out. So they're all targeting B cells. Daratumumab is a anti-CD38 antibody, which is used as the rituximab for myeloma cells, for plasma cells. So this is now being added to the Cyborg type regimens for multiple myeloma. Traditional chemotherapy therapeutic agents are still used. We still use cyclophosphamide. I've never used melphalan in like forever, but sometimes people use it. I don't think I've ever used melphalan after 2001, maybe. I've not used fludarabine. Bendamustine I've had a hematologist do for me. Immunomodulatory agents, again, I use hematology colleagues to help with that because they're very, very used to treating this. We're not as used to treating patients with these drugs. There are novel anti-lymphoma agents. Ibrutinib is an anti-BTK protein, venetoclax, etc. And then sometimes you actually have to do an autologous stem transplant, just as we do it for amyloid. So it is a conversion process. We have to understand that these kidneys are at risk. We have to understand they'll end up on dialysis if we don't treat them. There is a risk of progression to myeloma as well, but usually it's in the 1, 3, 4% range. It's not very high, but the antibody is such that if you don't turn it off, you get into trouble. So how do you deal with this? So let's go over three. So Jean Hogan actually published this paper in 2016. So I've lifted all the 3 cases he had in there because they make some very, very good points of how to think about these disorders. So again, this is the same picture, PGNMID. We'll use the same lesion. The patient comes in, some kidney dysfunction, proteinuria, and you biopsy them and you find PGNMID. It's a monoclonal PGMID, right? IgG kappa there. He's got 4.2 grams of protein. GFR is low at 43. That's your clinical picture. Now you start looking at it. So what's the first thing we're going to do? We're going to look for a paraprotein. You run it in the blood and you have an IgG-K paraprotein at a fairly low level, 0.1 gram per deciliter. In olden times, we said, oh, this is Mgrs, nothing to do here. Let's follow every 6 months. But now we know better. We know that this is a small amount of protein, but it is wreaking havoc in the kidney because it is toxic to the kidney. It's leading to an inflammatory response there, and this kidney will die if we don't do much about it. We do a bone marrow now because what are we doing the bone marrow for? We're trying to find the clone that is making this IgG-K because we want to find if we can shut the production of this IgG-K so that the kidney may heal itself. So what we find in the bone marrow is a kappa-restricted B-cell clone. Oh, we were not expecting that. We were expecting a plasma cell clone, but this is a kappa-restricted B-cell clone. It is CD19 positive, CD20 positive. Good, we have our target. They do peripheral blood flow cytometry, and they found a monoclonal. So this is what is known as next generation flow cytometry now, and it's becoming more and more popular. But in any ways, you've got a monoclonal B cell population in the blood as well. So now we're getting somewhere. We've got a lesion which is being driven by this paraprotein. How do I know it's being driven by this paraprotein? Because that's the paraprotein I'm actually demonstrating in the kidney. The paraprotein is being produced by B cells. How do I know that? I've got this clonally restricted B cell population in the marrow, which is actually throwing some B cells into the blood as well. So how do we treat it? It's a B cell population. We give them rituximab. 3 years later, GFR 68, there's no proteinuria. Hallelujah. We have got success. So this is how we think about what to treat them with, because we're trying to destroy this clone. We're trying to destroy this clone so that the protein coming out into the blood is cut off so that the kidney can heal itself. If you can find these patients and get to them soon enough, you can have good results. Now, this is reporting bias. This is a case that did well. So you have to be very careful in selecting these patients because these are toxic regimens, all of them. Select these patients well, counsel them well, and make sure you're doing everything to minimize infection risk, etc. Now, if I remove this PGN-MID and put something else in there, this will remain the same, right? So that's where the exact histopathology, although it's important, I'm trying to simplify it too much, but the mechanism is what is important. Now, second case. Now, same case, same histopathologic finding, PGN-MID, same picture. This time we're finding an IgG lambda there, right? Different type of paraproteins. Again, GFR is significantly low, 5 grams of protein, IgG lambda there. You go hunt for the paraprotein in blood, and you're able to find an IgG lambda at 0.7 grams per deciliter. All right, so far so good. Now we've got some correlation. There's something in the blood which is depositing in the kidney and causing a problem. So that's not good. We need to shut this off. How do you shut this off? You go find what's producing it, right? So now we do a bone marrow, and the bone marrow morphology is completely normal. We do bone marrow flow cytometry, and we are able to find a clonal plasma cell population, which is lambda restricted. Very good. That's what we wanted. We wanted somebody making lambda protein. So we know that we've had our target. How do you know it's plasma cells? It's CD38 plus, it's CD138 plus, it's CD19 low. So it's lost its CD19. So B cells, when they go towards plasma cells, they lose their CD19, they lose their CD20, they gain CD38, and a bunch of them develop, depending on where they are in their life cycle, 138 as well. And so now we know that this is a plasma cell clone, which is producing this IgG lambda monoclonal protein, which is of renal significance because it is depositing in the kidney and it is causing pathology. So this patient was treated with anti-plasma cell therapy, Cyborg. 18 months later, GFR is up, proteinuria is in full remission. Very nice. So this is how it should work. This is not how it always works, that this is what we strive for. So again, I don't want you to go away with the impression that everything screws up. Sometimes you can't find this, sometimes you can't find this. Sometimes you treat them and nothing happens, but many a times it does as well. So I actually had a PGN-MID with a IgG lambda, I think, and I treated them blindly with rituximab and was following up with Cyborg, and they romped into dialysis from a creatinine of 1.4 to renal replacement therapy range in about 3 months. Didn't give us a chance. So sometimes these things are relentless. All right, so this is the same histopathological designation, PGN-MID. Again, we have an IgG kappa this time, nephrotic range proteinuria, not nephrotic syndrome, but nephrotic range proteinuria, and a significantly decreased GFR. No light chain, no paraprotein detectable. Everything's negative, and this does happen, especially in PGN-MID. You're able to find a paraprotein in about 25 to 30% of cases. So 2 times or 7 times out of 10, you're not gonna find a paraprotein in PGN-MID. That's problematic. So this is what's happening in this case. Bone marrow, nothing. Everything is clear. So there's no clone. Bone marrow morphology is done. So what do you do now? You've got a target here. You know that there's an IgG kappa. You can't find it in the blood. You can't find it in the marrow. So this person was given a hybrid regimen. They got cyclophosphamide and rituximab, and they had a good response. Proteinuria went away. GFR came up from 32 to 48 at about a year time. But sometimes it doesn't work that way. Sometimes you have to give what is known as sequential therapy. You would start with one, doesn't work, go on to the next. I was trying to do that with my patient. He just didn't give me time. He's actually gotten transplanted now, so not a bad story. But these things can be relentless. But these are difficult diseases to treat. So therefore, what you need to develop is an ecosystem to take care of these patients. You're here, you need a good pathologist. And in Pakistan, since you don't have electron microscopy, what you need to do is to develop as many techniques on immunofluorescence as you can to at least give you the answer. The good thing is for MGRS syndrome, if you've got a good immunofluorescence designation, you can make a diagnosis with some degree of confidence. And you need a hematologist. He needs to be able to help you devise, think about, and then run some of these very difficult regimens. These are all toxic therapies, and in Pakistan, as insurance is not available, these are very expensive therapies. But on the other side, you have the specter of end-stage kidney disease, and then you need to be in constant touch with transplant centers. When these people crash and burn and go on dialysis, and if you've not treated the clone, or if the clone is still there, guess what's going to happen after transplant? They'll have a fairly high likelihood of developing a recurrence in the allograft. So PG and MID can recur in about 60 to 80% of kidney transplants. Not 100%, because sometimes the immunosuppression with the transplantation kills the clone, which is great. We like it. So this is definitely a team sport, and you need to have your team designated for these very, very difficult patients if you want to do this well. And finally, the truth is out there. I mean, there's a huge number of these patients who are never diagnosed. A lot of them, because diabetes is very common, they develop kidney disease, they've got proteinuria kidney disease. You say, wow, they got diabetes, and you never look. So underneath that tip of the iceberg, there's a whole lot of these patients who are not diagnosed. And why? Because we haven't changed. So this is that grocer who had drunk too much alcohol and fell down and hurt his ribs. And I think now we know that he had lytic lesions there and he fractured a rib. His death certificate says atrophy from albuminuria certified. So that's the diagnostic formulation then, but they didn't know what to do. We do now. So we need to work diligently to diagnose these patients accurately and then treat them with precision and safety. So I will stop here and I will invite any questions. We are just on the hour, so perfect timing.
Thank you, Dr. Agha. I think this is probably one of the best presentation about MGRS I've been to. So thank you. Dr. Tarif, you have a question, and I would like to share one of my patient in the story, but let's start with the questions first. Naman, please go ahead.
Assalamu alaikum. I think it becomes an echo just saying, how wonderful the lecture was. But I have to say, I mean, you are excellent in your presentations and so clear that I really love it. And, looking at the whole scenario, it seems that every biopsy where you have at least an MPGN or membranous GN now, you should do a Kappa lambda. We're not doing any Kappa lambda immunofluorescence routinely, only in certain cases where we ask the pathologist to do it because it adds to the cost. Recently, I had a patient who had membranous GN, and he also had this serum protein electrophoresis, which was positive for a paraprotein, and it became. And I got confused, where to go. And the PLA2R I've sent it, it's not come back. So I think the lesson, one of the lesson here is that we should probably be doing the Kappa lambda in all our biopsies as a routine cases. What do you suggest?
Yeah, Einstein once said that make things as simple as you can, but not simpler. So I understand the cost dynamic, and that's a very real problem in Pakistan. So I don't want to minimize that. But we're doing these biopsies, we're putting the patient through so much trouble and risk. So we need to get the best bang for our buck in these cases. So I think if it's not terribly costly, I echo your sentiment completely that Kappa lambda staining should be done. Maybe there is a pathologist on the panel who can make us wiser on this. But as a treating nephrologist, we obviously would insist on getting Kappa lambda staining, and it's done routinely here. Because sometimes it's just through the Kappa lambda staining that you say, well, there's something not quite right here. And that's when you start looking at it in greater detail and find out, oh, there's a clonal problem here, and then you address it. So no, absolutely, I think that goes without saying that if it's not logistically prohibitive, it should be done. And I can't imagine that it would make that much of a huge difference when everything else is being done.
Irfan, I have some questions in my mind and I would like to, so let's start with very simple approach question. When you see a new patient with CKD and proteinuria here and there, you know, sometimes you have proteinuria, which is very mild. Sometimes it's maybe 0.6, like 600 milligrams. Do you check SPEP, UPEP, and immunofixation routinely for all or most of your new consults with a certain age group or not?
So I actually do. What I do is, if they've got proteinuria, so proteinuria, if they've got a protein creatinine ratio of 300, 400, I wouldn't bother. So if they've got significant protein in the urine, gram plus, 500 milligram plus, and they're, in an age group where I worry about some of these things, so let's say 40, 45 plus, then when I'm doing my initial laboratory evaluation for CKD, and I used to do that. I don't do a lot of CKD clinic now, so I get them when they're already diagnosed now because I see them in the GN clinic. But what most of us do is if they've got some degree of proteinuria, 500 milligrams to a gram plus, we would routinely check a full screen for monoclonal proteins. If it's negative, hallelujah, we're good, we've done it, we're fine. If something comes up positive, then we look at it again and see what should be our threshold to biopsy.
So I have some similar kind of practice pattern as well, and sometimes our fellows and everybody they I challenge them and they challenge me. It's like, why are you doing this on a lot of patients? So I actually have been successfully able to diagnose fine because we were just looking for these early MGRS and treated them at such a good stage that you knew that it was leading towards that catastrophic stage. So there was some sort of a juice. So we felt like, it's really a good worth squeezing. So my patient, 62, 63, creatinine was 1.4, 1.6, sometimes 1.3. Proteinuria, sometimes positive, sometimes negative. SPEP, UPEP, nothing was very crystal clear. So the Kappa was slightly high. The ratio was maybe, so nothing was very crystal clear towards any particular thing. So, okay, let's do kidney biopsy, convincing a very busy person to do a kidney biopsy. So I said, like, that's fine. We can arrange like a Friday afternoon. So Saturday, you don't have to work and all that. So did the biopsy. So in the serum, so in the urine, there were no abnormal proteins. In the serum, the level of Kappa was just borderline high. But on the kidney biopsy, so imagine if this is a capillary loop, and I explained, I think we were sitting with the fellows, so they said like, so I said like, imagine you are sitting inside the capillary loop, and then four walls of the room, roof and floor, they are kind of, you're sitting inside, so that's the room, that's the capillary loop. So everywhere on the membrane, there were deposits. So this was like, monoclonal deposits, like everywhere in the membrane as well as in the mesangium. Patient also had an issue with the potassium, which was kind of more recent. Blood pressure was really off the charts again in the last, few months or so. And then we saw some of the loops were closed or at the verge of closing. Pathologists, when they looked in the tubules, so there were those proteins everywhere on the tubular membranes as well, basement membrane as well, because that's where the reabsorption is happening. So tubules were probably working at the top of the license to reabsorb all the proteins. So we are not seeing much of that in the urine. I think the case was very, obvious after the renal biopsy. Before that, we did not have any clue. So bone marrow was done negative, the skeletal survey, everything. So we could not find the source which you just mentioned. But I think so we convinced and asked the patient to be treated. Patient wanted to get second and third opinion, and I think patient got the same response everywhere, that yes, there are a lot of gray zones, but anybody who saw the kidney biopsy, they said, like, what, if you delay, you will go into renal failure. So then the creatinine started to go up from this 1.6 to 2.2, and then treatment was quickly started and had excellent response. So creatinine came back.
How do you treat it?
Bortezomib and rituximab both.
So that's perfect fine. You did a hybrid regimen then.
Yes.
And that's perfectly fine because you didn't have a target clone. And
yes.
It was an IgG Kappa, you said?
I think it was Kappa.
So more likely to be okay.
So, and then patient had a very good response. Proteinuria started to go slow. It has not gone completely. So you still detect some, but it certainly improved. Creatinine actually improved from that, it was all the way up to 2.2. Now it's back to 1.4, 1.6. Even potassium, which became like a problem that I had to use K-Exalate 2 or 3 times a week. I just stopped because I think patient during the treatment, of course, lost some weight. He was already thin, lean, and tall to begin with. And then now I just, saw him, he's going to retire very soon. But at least he's happy, he's disease-free from the hematologist.
We don't know that yet.
We don't know that yet. At least, from the hematologist markers, from their recommendation.
The problem is, and that's, I think, a point worth making. We really have no markers here at all. Mm-hmm. Because you didn't find a clone, right? So what are we treating? And the paraprotein was so minimal that, what are you going to look at that for? So you don't have hematology markers here. The only markers you have are the kidney markers, because that's what we're treating right now. So those markers are in the right direction. You didn't have a lot of proteinuria. You said sometimes he had protein, sometimes he didn't have protein. He didn't have a fixed high rate proteinuria. So if he had 3 or 4 grams and he went down to 300 milligrams, I'd say, okay, yeah, we're making some progress. So proteinuria itself, but the only thing is the kidney function, which has gotten better. But you can actually, if I want to play devil's advocate, I could say he had an acute tubular injury along with that, and GFR dropped and GFR got better anyways. So right now there's confirmation bias, there's treatment bias. We treated it, it got better. We don't know yet. And sometimes in these cases, you might need to do another biopsy at an interval to see where things are. I would let sleeping dogs lie as long as the kidney function is okay, he's doing all right. But that's kind of sometimes the burden because we don't have good markers to treat these clone negative disorders. And the path was read as PG and MID or what?
I wish I should have, maybe like opened the biopsy report. I cannot open on this. But I think so. So, I mean, it's going to be like challenging to convince him to do biopsy. But I think now, since you're saying it makes sense. So I have an upcoming appointment. So maybe I will kind of socialize the idea that we keep an eye on these markers. This is what we do the track. But anytime things are, a little bit out of the track, it may not be a bad idea to do a biopsy to see the response to the treatment, to make sure there's no chronicity and see if there is any active disease, we can, tackle that. But I feel good just by taking the extra effort to detect this and did not accept, did not settle down. So just keep chasing. And in the end, I think so far we have a good outcome. We have 2 hands raised. So I'll stop here. How about if we start with Dr. Aurangzeb Afzal first?
Before you go there, let me just make one point that this disease requires a lot of strength to treat. So, you went out, gave him rituximab and bortezomib. Power be to you, because a lot of people start finding ways not to do this, right? Because they're worried, oh, I don't want to give this chemotherapy to this patient. But once you start doing this, you realize that if I was trying to treat membranous and you were trying to do Ponticelli is 100 times more toxic than Velcade and rituximab. It's, the amount of steroid you give those patients, the amount of cyclophosphamide, that is a much more
concerning regimen, and we won't bat an eyelid if you were treating membranous. So we shouldn't bat an eyelid when we are treating these patients. I think you very, very successfully, very likely saved this guy from dialysis in 2 or 3 years. So I think you really made a difference, and it required some strength to go out on a limb, do all this and treat him. And this is the burden of this disease, or this group of diseases, because sometimes you really have to push for what's right.
Thank you. So Aurangzeb, please go ahead, and then we'll come back to Dr. Tariq.
Assalamu alaikum. So first of all, thanks once again to Dr. Agha. I think he sets the bars too high. MashaAllah, it was a wonderful lecture. And as you said, Dr. Umar, that it is probably one of the best that I have heard on MGRS. So I have one comment to make, and then I have a case, and I want the guidance from all the panelists if they could guide me. One is that Kappa Lambda staining in Pakistan regarding Shaukat Khanam, they started doing it, but then the pathologist told me that there is some issue of validation. So we aren't really sure that even if we ask for Kappa Lambda, so is it worth believing in or not? Though if we request them, or for example, all the patients who are having C3 greater than 50 years of age, and we are expecting something like that, I routinely request them to do Kappa Lambda on it. Pronase digestion isn't available over there. They do it, but I don't know how much we have a belief in it. Secondarily, I would like Dr. Irfan Agha to suggest at what threshold should we be ordering flow cytometry for peripheral lymphocytes? And lastly, case. Now, once again, the difficult cases are usually in the doctor's families. So this is also a mother of a doctor from country in interior Punjab. And this patient presented with us disparity between the proteinuria, single positive protein on dipstick, and proteinuria of 9 gram, I think so, on quantification. So that started the story, and GN screen was completely negative. Then monoclonal protein was detected, serum protein electrophoresis was positive. Kappa lambda ratio was, I think, 2.9, and with a creatinine of almost 3. So it wasn't really something that I can bank upon. Serum immunofixation, urine protein electrophoresis, all were negative. Patient was subjected to bone marrow biopsy as expected. The clone wasn't there, almost 3% plasma cells, if I could remember it correctly. Renal biopsy was done in another institution. Unfortunately, which is a really unfortunate event, only histopathology was done, and it turned out to be proliferative glomerulonephritis. Immunofluorescence section sample was not there according to the report. So now I was left with the suspicion of MGRS with the proliferative glomerulonephritis and maybe MID, but immunofluorescence was never there. As Dr. Agha suggested, that communication with the hematologist is usually very tricky, because 2 leading hematologists told me just forget the monoclonal protein and consider it as a renal disease and treat it. So I started counseling them from a rebiopsy. Unfortunately, the patient started having Coombs negative hemolysis with a thrombocytopenia that prevented the renal biopsy. And now everything was controversial. I have MGRS, but I don't have any evidence of monoclonal immune deposits in the renal tissue. And on repeat examination, the patient had normal serum protein electrophoresis, again from the same good lab, one of the leading labs of Pakistan. And the patient started having a rise in serum creatinine from 3 to, I think, 4.5 or 6, with the same disparity in the urine and quantification. I'm sorry it got a little long, but I really need your guidance regarding cases like that. That how should we do it? Ultimately, this patient was given rituximab with steroid, and cyclophosphamide was not given, and it was my decision because most of the hematologists did not say that anything should be given from monoclonal protein point of view. Creatinine improved, platelets are still in 60s, and the patient is not ready to get another injection. For a case like that, how would you proceed? I wonder you don't have that kind of problems in USA where immunofluorescence is missed or something like that. But if it happens so, how would you treat this case? Creatinine is 2 now, 4 from 4 to 2.
Yeah.
No serum protein electrophoresis.
So let's have the panelists weigh in. What do you guys? What would you guys do? I'll definitely make my views known as well, but let's have the panelists weigh in first. Professor Tarif, what would you think, sir?
Well, I mean, this patient has Combs negative hemolysis. Where would you put that? You know, I mean, is it the part of the picture of the whole disease itself, or is there something else going on? I missed probably the biopsy was okay. I think less than 5% was the plasma cells, as you said, maybe 3% you said.
Yes, sir.
So, yeah. So I don't know. I mean, everything is so. There's so many missing points there that you'll have to. You just have to treat. You know, whatever you get, and you just follow that lead. Especially if the patient is not that compliant.
No, I agree 100% with your assessment. So this is, like Aurangzeb said, an unfortunate situation, and he's trying to pick up the pieces now. So essentially, Aurangzeb, I would differ with one statement that you made, that she has MGRS. We don't know that. We haven't established that she has MGRS. She does seem to have some form of a peripheral clone. At least one of the SPEPs were abnormal, but we don't have further definitions on that. But we have not been able to demonstrate that on kidney biopsy. That's where the immunofluorescence was vital in this case. And unfortunately, we don't have that. So, I mean, she could very well have post-infectious GN. I mean, it's a proliferative GN. It could be lupus, for all you know. Could be something else, but we don't have immunofluorescence, so we can't make that determination. So in the US, if I were dealing with a situation like this, I would rebiopsy. Sometimes it does happen, you don't get enough tissue. They say, well, we only have for light. We can't do EM, we can't do immunofluorescence. This is what it is, right? You didn't get enough tissue. So we tend to rebiopsy because you cannot make a complete diagnostic formulation based on just a light microscopic picture here. So it's an unfortunate situation. It's kind of like Dr. Tarif mentioned. It's important to see where does everything else, you know, is this some form of a cryoglobulin, which is leading to cold hemagglutinin disease or something, which your Coombs test is not picking up? Could there be something like that going on? And is that part of the monochrome protein that you intermittently picked up? So I think we need to get a little bit more clarity on that. But to treat the kidney lesion with significant immunosuppression, she's actually gotten some already. You probably would need to end up rebiopsying her. And if you can't do a rebiopsy, you've already treated a B cell clone. If there is kidney which is salvageable, that is not a lot of fibrosis there. There's the possibility of continuing some steroids, trying to see if that would help, versus considering a plasma cell-based therapy. But I wouldn't venture in any of those directions without having a diagnosis, not in the United States.
Right, sure.
Yeah.
So if thrombocytopenia,
if she develops an infection, right? Then you'd kind of say, okay, why were you treating this? What were you treating? and we don't have that diagnosis yet.
So that is exactly true. But how would you fit in the disparity in the proteinuria? Single positive protein and sometimes no proteinuria, still quantification yields almost nephrotic range proteinuria almost always.
Yeah.
If this patient is having a thrombocytopenia persistently in the range of, let's say, 60s, and I don't know if it's an ITP or with something else going on, all the GN screen, rest of the things are negative.
Yeah.
So that is just a single case. I totally understand this is a confusing case, but I want to learn is what is the threshold for advising flow cytometry for peripheral lymphocytes? When do you advise it? And when the patient is having a CKD, it's very easy to say that you should scan the body and go look for other things in the thorax. But we don't go for CT with contrast if the creatinine is deranged. So that is also a limiting factor sometimes.
So a couple of points on that. So peripheral lymphocyte cytometry is done to look for clones. So when you're looking for a clone, there's 2 or 3 things that you can do. I didn't go into too much of detail because it becomes esoteric and probably is not directly relevant to practice in Pakistan. But what you can do is, the first thing you do is bone marrow biopsy. Then you can do peripheral blood flow cytometry. Sometimes, we end up doing a PET scan trying to see if this is a solid-phase secretory myeloma somewhere outside the bone marrow. And sometimes you end up doing whole body MRIs trying to find that one lytic lesion somewhere, which would kind of home us in the right direction. So you kind of get into these minutia of some clone hunting exercises in some patients, but those are not your everyday routine. Right now, you're not even at a point where you know if this person has an MGRS syndrome. So the first thing to do is to establish that. We have got nothing that tells me that this person has got MGRS. You first have to establish MGRS. Once you've established MGRS, then you can go ahead and start spending money on other things. But unfortunately, here we don't have that diagnosis.
So I will go to,
All
I think we have 2 hands raised. Thank you, Aurangzeb. Do you if you have, is this okay if we go back to Dr. Tarif and then Dr. Zafar?
On the same case, sometimes the histopathologist can do immunohistochemistry on the slides that you have. They can destain and then restain or something, if you can push them to do it. So that could be one thing. And I agree, with Omar, that you had asked for rebiopsying the bone marrow, because the patient developed thrombocytopenia later on and a hemolysis. Maybe there's something else that we are missing there.
Thank you. Is this okay if we go to Dr. Zafar then?
Yes, please. Assalamu alaikum, everyone. I appreciate for such a nice session with a clear view. I think we should have another session to summarize all these cases. But I have one simple question with Dr. Agha or Dr. Omar. Like in the nephrology clinic, we screen above 50 for proteinuria. We do SPAP and UPAP. I'm working actually in Qatar as a nephrologist. So just I want to get your comment, like we should do both these tests for screening or one is enough? Because latest Nelson article was saying that in the urine is not so important, serum is more important. What's your thought about that?
Yeah, so essentially what you need to do if you're looking at it from a cost-effective standpoint, you need to do a serum protein electrophoresis with immunofixation along with a kappa lambda ratio. And then if you can do it, a urine protein electrophoresis with immunofixation sometimes helps you with amyloid. So that may be the only thing that turns up positive. So when you're hunting for these proteins and they're present in only percentages of cases, each additional layer of testing improves your sensitivity. So if you've got an SPEP and UPEP, your sensitivity is in the 80s. If you've got an SPEP with immunofixation, you get up to the 90s, mid 90s. If you've got an immunofixation, SPEP with immunofixation, and a kappa lambda ratio, your sensitivity on picking up a clone, picking up a paraprotein is somewhere in the 98-99%. So that's what's recommended.
Great. Thanks.
And so I just wanted to get an answer for one question. I think it's missed. What if there is a disparity between dipstick proteinuria and quantification repeatedly? And we sometimes get SPEP positive, sometimes we get it negative, just like in this case.
Yeah. So
how would you fit in that?
Two scenarios. First of all, there may be a non-albumin protein. So the dipstick is going to only pick up albumin. So if the protein that you're getting in the urine is a non-albumin protein, and in this case, if it's a paraprotein, right, it's not going to be picked up by dipstick, but it'll be picked up on the 24-hour specimen. And then you have to really keep in your radar screen the possibility that the dipstick may not have been done properly. So it was a poorly done test.
So there's a possibility, but I think I have repeated it almost 3 to 4 times now from I think the leading lab from Pakistan.
Yeah. And so
I just want to reiterate the point. Sometimes in Pakistan, the immunofluorescence, it's not that helping. I know I sound a little counterintuitive while saying it, but if the kappa lambda staining isn't available and the patient is having an SPEP positive with a disparity in the proteinuria, which is usually confirmed from a good lab, sometimes that is all the information that we get, because kappa lambda ratio is in the upper range, maybe 3. I have a patient that has exactly 3.2 and has a disparity.
Yeah.
And of course, the hematologist doesn't help, and the plasma cells in the bone marrow are usually less than 10. And there is only a single answer in that case, because the kappa lambda staining wasn't done by the local histopathologist. So the answer is the same. Go ahead with the renal disease. There is nothing in the blood.
Well, that's actually sometimes what we hear from hematologists here as well, and you have to sit them down and kind of walk them through this. So it's something which is emerging. So sometimes, hematologists here in big institutions, they fall off their chair when I tell them what I need them to do for a particular patient. They say, "Are you crazy?" And then you have to kind of walk them through all that. Now, the scenario that you were pulling up, which is dipstick is negative and the urine has high-grade protein in it. Obviously, the question is this non-albumin protein? So the only thing that I would say is that if you've got that much of non-albumin protein in the urine, like 3 grams, 3.5 grams, your serum screens for paraproteins would be positive as well. It's unlikely to have that much non-albumin protein in the urine and not have a signal in the blood at all. So.
Yeah, so as I was listening and I was thinking the same thing, that if you have that much non-albumin protein, this is very hard to believe that the SPEP was negative. So other question I have, Irfan, from you, if you do that immunofixation almost all the time, then why you have to do SPEP? You can go ahead with the serum immunofixation to begin with.
Yeah, no. So the immunofixation is on the biopsy.
No, I'm talking the serum immunofixation.
Oh, no. So the serum immunofixation, like I explained, increases the sensitivity of the test.
I know. So you do the SPEP first, and I'm like, then do the serum immunofixation.
Right. And the other thing that the immunofixation does is it gives you the class of the immunoglobulin. So you can then say there's not just an M band. The M band is because of an IgG kappa protein.
Yeah, I think the question which Vas is asking is like, why should we do the screening SPEP? Why can't we just do immunofixation as the only test?
I ordered the SPEP with immunofixation by default. I never ordered the SPEP alone. So the immunofixation has to be done on the electrophoretic panel, right? So when you do serum immunofixation, that's the test you're ordering. Your serum protein electrophoresis with immunofixation is the test you're ordering. So yeah, there's no point in determining the M protein. What you want to do is, what is the type of M protein and what is the strength of it? That's what you're trying to ask.
So the strength question will be answered by the SPEP part?
It can be answered by both the M protein. So it'll say M protein is 0.5 grams per deciliter, but the immunofixation will say the M protein is because of an IgG kappa and it's 0.5 grams per deciliter. So it gives you more definition. But Avas is asking a philosophical question that, why are we doing it a certain way? And he's right, because, if you have it, you just want to get the immunofixation. Why would you want to waste time and effort doing one test and then ordering another one afterwards?
In this case, where they have negative SPAP, if they would have availability of serum immunofixation, probably that would have been the answer in that case.
That is correct. That is correct.
So one of the lessons learned is that it might be slightly easier to practice in a resource, when you have all these access to all these tests and pathologies and biopsies. And not only that, you will get the answer, but if you need a repeat biopsy, it's easier to convince the patients even, that this is the need and you can do the biopsy. I think Aurangzeb and my colleagues in Pakistan, what you do is wonderful,
It's very hard
without.
No, I
Yeah,
mean,
we're wonderful and controversial.
It's actually
It's always controversial to take decision in Pakistan, because somebody somewhere will diplomatically somebody will criticize, and diplomatically that person will be correct. Whatever the decision that we need to do, sometime in Pakistan we don't take a decision that may be the right decision, because of the available evidence isn't completely focusing or isn't completely convincing us towards a diagnosis, but we still have to take a decision.
Absolutely. I mean, it's easy to criticize, but very difficult to give the answer what the solution is there.
No, I think the lesson for Pakistan is that, we've got like 20 odd nephrologists from Pakistan on the line. Like we talked about immunofluorescence studies before, electron microscopy is a harder problem because it's the capital cost is very, very high, but immunofluorescence already exists over there. It's being done. So adding more immunofluorescence techniques, I think, is an easier lift. And I think this should be considered standard of care, and we should probably ask the pathology team to work towards that. Although I'm probably being naive and Pollyannish about it, but we should insist that that's something that we need. But I will make a point about what Umar was saying. It's not just in Pakistan. Practicing and treating these diseases in the United States is very hard. You get out of a big center, get out of a big university program, drive 20 miles and you're facing the same problems. So these patients need to be seen at centers which have some expertise and some bench depth in their pathology support, their hematology support, to be treated appropriately. These are really difficult cases. None of them is as straightforward as I made them look like in those 3 cases. Life is all gray in these cases.
And so what about that TMA part where there are no deposits, POEM syndrome? This is something that I have read. I am yet to see a case of that.
Yeah.
Have you seen a case, and what is the experience regarding it?
I see this all the time, not in MGRS things, but antibody-mediated damage in the post-transplant world. So antibody-mediated damage to the endothelium leading to TMA is very, very well described. I have not seen an MGRS case leading to TMA. I've seen several leading to C3GN. So.
Yeah, this is not a typical case, but otherwise TMA doesn't cause that much proteinuria, would it?
It could. It could, depending on what the degree of damage is. But it's not going to be like 20 grams of protein. At tops, you're going to be looking at
more like amyloidosis, it sounds like.
So it's an endothelial lesion. It's not a podocyte lesion. So, I'm sorry, Dr. Tarifi, you were saying?
Sorry. For that case, Dr. Aurangzeb was mentioning could be a TMA with the low platelets, and hemolysis also there.
They did not. They did not pick up the TMA lesion on histopathology. They called it a proliferative GN.
Yes,
I
but
mean, it was an
at that
evolving
time, there
disease.
wasn't any thrombocytopenia to begin with. Thrombocytopenia only developed later. And initially,
Yeah,
the thrombocytes were normal. So that is also the case, but polyneuropathy is a little difficult to define. There wasn't any history, but I was thinking on the lines, but it wasn't point syndrome as a whole. So that was, I was asking, once you get a MGRS, is it always a complete point syndrome, or you can just have a TMA with MGRS? I haven't seen a case.
Yeah, I mean, it's well described, but I don't know. I mean, I don't want to actually conjecture too much in this particular case, because it looks like our data points are scattered and not probably completely reliable at this time. So what I would recommend in this case is wipe the slate completely off and then reevaluate everything in this patient. See if there's a thrombotic microangiopathy and a microangiopathic hemolytic anemia here. See what the degree of proteinuria is, see why there's anemia, see why there's thrombocytopenia. Is this Evans syndrome? Is this microangiopathic hemolytic anemia? Is it two different etiologies which are driving this? And then, if you're really, really serious about diagnosing what's going on in the kidney, you probably will end up needing to do another kidney biopsy, otherwise you'll be blind to what's going on. This is not a good situation, and I'm so sorry that they didn't do the complete evaluation when they had a chance to do it, but it is what it is, and we have very incomplete information here. And so to draw long arc conclusion on this is going to be hit or miss. We may hit the bird correctly, or we may be completely off track. And the treatments that are being proposed are fairly radical and potentially toxic, so we got to be careful. First, do no harm.
Well, the thing is, they got second opinion from some of my colleagues, and it was like that. This is a GN, but no specific treatment was really offered, and some degree of steroid was given. So I thought that there are some. It's a scattered case. I totally agree. But even with this scattered case, the difference of opinion is massive. So
the less,
they got almost,
the less the data, the more verbose the differential diagnosis becomes, right? That's why you gather the data to whittle down the differential.
But my feeling is that this is not GN. This is not GN.
Well, actually, to be honest, there is
well,
they're saying,
on histopathology, let me say, it was an endocapillary proliferation, complete proliferative glomerulonephritis.
And here to throw some other antibodies to us, and we again start with more tests and waiting for another year or so. So, rapid development.
But yeah, do give us a follow up on what happens, Aurangzeb, because that's an interesting situation, and we'll see how you tackle that. I'm glad you're taking care of her and not I.
Yeah, I think once the thrombocytopenia settles, that I'll surely do a renal biopsy again. Luckily, after rituximab and some steroids, the creatinine has improved. So that is the good part.
It may just be a garden variety immune complex proliferative GN, which has gotten better with immunosuppression. So you might have hit that nail well. So good.
Yeah, but I think if it was an immune complex, it should have given us something on C3 and C4, which were persistently within the normal range. So probably yes, still it can, I'm sure. You're right. Thank you so much, sir. Once again, a fantastic talk. Bless you for that.
I have a question. Maybe one last question. During the treatment of MGRS or multiple myeloma, sometimes you go for the plasma exchange if the load is quite high. I had a patient similar, a few years ago, and we ended up doing it and the plasma exchange, and it all just clotted. And it later appeared that, just went through that during plasmapheresis, some of these special kind of antibodies, they can clot very easily. Is that the case, or we have to have some special precautions when we do a plasma exchange if we have to?
No, I mean, we actually do it without any specific precautions. So there's two different types of therapies that are used with a great deal of controversy, I might add, in myeloma. So not in MGRS as a routine. There are some case reports of plasma exchange being deployed in certain scenarios in MGRS, but not very commonly because the antibody burden is not very high. But in myeloma, when you have florid, high level, a high burden of light chains, and you have past nephropathy and acute kidney injury, sometimes people either use high cutoff dialysis, which is done in Europe. It's not approved and available in the United States. Sometimes we would do plasma exchange to lower the burden. There's an institutional effect. Some institutions like to do it, some don't. But the fact of the matter is that if it's a relatively acute situation, once you start treating the myeloma, it melts away very, very quickly. We do know that the volume of distribution of those light chains is very high. So there's a fairly good rebound after plasma exchange. But once you stop their production, they go away very, very quickly. So some people would just treat it. Some people would use plasma exchange with discretion only in patients with the very high levels of antibody. You can find some signal in data for both approaches. So I don't remember doing plasma exchange for a long, maybe once or twice, but I've not done it very frequently. What do you guys do, Umar? Do you exchange, not exchange?
No recent experience for such situation.
Because, this was all done when we didn't have effective myeloma therapy. Now with Cyborg and now with daratumumab, you can melt away the tumor in days. So the advantage of that is gone.
Yep. So I think it's going to be 3 p.m. soon. So one comment or a question, there was a question from the group as, is EM, electron microscopy, available anywhere in the Pakistan or on any other center? My understanding is that it's not. If anybody disagrees, then I think at least we have the answer.
It's available in SUIT. It's in the Institute of Urology and Transplant.
Oh, so it is available in SIUT.
Yeah.
Okay.
We have installed a new microscope, but it's still not functional. Maybe in the next few weeks, it will become functional.
Okay. So any final questions, comments? If not, then I will ask Jessica to do the conclusion. Anybody wants to say something?
Yeah, Assalamu alaikum. I'm Dr. Kasser. Very nice discussion, and there was talking about the resources, and you are very lucky. You are working in USA, where you have very normal and rational practice. In my country, when everybody is doing all practices like hakims, homeopaths, sannyasis, and we don't know how much medicine they are giving to a patient. So what to speak about a biopsy, which patient is afraid of? And one patient, we did a biopsy, and unfortunately she got a CVA of that side, and they blamed us that you did the biopsy and CVA occurred. So this sort of practice we are in Pakistan, and hope for the best. But you guys are doing a great work in USA, and we are learning from you. Inshallah, time will come that we will do the same practice in Pakistan, inshallah. Thank you very much.
I think you guys are doing a difficult job than us. Our job is relatively easy. You are you are in not a very good situation, but you use your brain, you use your thought, you do your clinical judgment to a greater extent than we do here, frankly.
Yes, thank you, sir. All difficulties, but inshallah it will work.
And Dr. Kasser, if I say something, one of the advantage which we have, and I feel we have, is that phone a friend, or we have a case conference, or you can just talk to somebody. So if I have something, I can call Dr. Agha, and this forum which we created is really to replicate that. I think you have expertise within Pakistan as well, who can actually sometimes guide you with the best practice that may work in the land of Pure. So we can tell you something which happens in USA, but your other colleagues who are in Pakistan can really do the same thing. That when I'm stuck, I will call Irfan, I will call Abbas, I would call some of my other colleagues, or we have our own case conference. So if you're stuck and you bring a problem, this is the forum when you have folks from Pakistan as well, so who can really guide all of us as what's the best possible way out from it. So I'll stop here.
Yes, thank you. Thank you. It's a blessing for us. Thank you.
Thank you. Jessica, over to you.
Thank you, sir. Well, I just want to thank everyone for your engagement and participation today. I'm glad that everything was so well received, and thank you to our wonderful expert team. You will be receiving an email shortly which contains a link to the session evaluation. We do appreciate your feedback, but that's also how you would claim your continuing education credits if that is something that is of interest to you. If you are not registered for this series, you won't receive those emails. So I put a link in the chat. I will also send the link for the registration in our follow-up email, and that will give you the opportunity to register, and then you'll be able to get emails from us and then also do those evaluations so you can claim some credits. We look forward to seeing all of you August 1st, and Dr. Agha will be presenting again. So we look forward to seeing you. Please email us, look for our follow-up email if you have any questions, concerns, and thank you all again for attending. Have a good afternoon, good night, whatever time you're watching this. We appreciate you and thank you for all of your input and participation.
Goodbye, everybody. Thank you very much.
Thank you. Khuda Hafiz.
Bye, everybody. Khuda Hafiz.